doing as groups. Okay, this is what you can be doing. And you can do it for each individual class of pathogens, like viruses or stuff like that. We're going to do it with the unfortunate wood chopper as best we can. This poor guy is going to go through hell this semester. So we're at the beginning of that, okay? So we're going to try to do this today. We just wanted to give you an idea of what you can do and give you an overview of an initial inflammatory response with maybe how the adaptive immune response may be responding. We're going to make it a generic bacteria, okay, even though it's likely to be, well, and Dr. Miller, has anyone seen Dr. Miller? Oh, okay. So he's missing in action because he's our bug person. Okay, so let's just start out. Because we think that if you ask questions as we go along, can you write your questions down as you go along? Because it will be here forever, okay? So we're going to start out with this, and then we're going to move into the review questions, okay? Everybody okay? Okay. Okay, so I'm just going to start out, and each one of us that handled different areas of lectures are going to spout words, pearls of wisdom for different components of this, okay? So here's and this is my artwork. Obviously, I'm a scientist, not an artist. This is the unfortunate wood chopper who has chopped into his leg with an axe. We were going to show some pretty gruesome pictures, but we decided not to do that. So it starts out, he obviously has made a wound through his epidermis and his dermis. Blood is gushing, okay? This is the immunology inflammation part, so we're not going to talk about shock or any of that sort of stuff. So, here comes Dr. Miller. So the likely bugs that are going to be there are probably going to be staph and pseudomonas, and I can tell you that. But this is going to be a generic microbial. So it's not specific for any microbe because we can't do that. Every microbe requires a different kind of immune response, and we just can't do it. It's too complicated. But you can. Okay, you can go back and address each class of pathogen. Okay? So he's chopped into his leg. He is bleeding profusely. The bacteria are starting to disseminate, and I will now turn it over to the inflammation people. And I don't remember which order, Dr. Allard. So what is the first thing that's going to happen?
Okay.
So we are trying to give you a sequence of events so that you're thinking about the big picture. What happens during an infection? Okay, what happens?
Okay, so actually before the bugs have time to start proliferating and causing problem, obviously there's going to be bleeding, there's going to be tissue damage, so there's going to be clotting. And remember, we talk about clotting and inflammation being hand in hand. So the first thing that is going to happen when plasma proteins get in contact with damaged endothelium and with extracellular matrix. Remember, this factor, Hageman factor, is going to get activated, and it's going to activate 4 different systems. Of course, the coagulation system, which is what this poor guy needs at the moment. But then this activated factor 12, or Hageman factor, is going to activate also the kinase system. We're going to have the end product, the bradykinin, that's going to cause inflammation, it's going to cause pain. But at the same time, also the fibrinolytic system is going to get activated, and all these enzymes are going to cleave also complement C3 and C5. So we're going to have production of C3A and C5A, which also have inflammatory activity. So even before bugs start working, we will have these plasma mediators derive inflammation. Okay? So, turn it over.
So remember that in the timeline there, this is going to happen very quickly. So obviously what Dr. Fernandez was talking about is happening immediately. And then the inflammation is going to continue for 24 hours, so at least. So here, now you have the bacteria. So this is the skin, and this is the vessel here. And you have resident macrophages that are going to be in the epidermis and the dermis. now you have the bacteria that start to invade the tissue because you have the breach of the epithelium barrier. So you have your clot, you have your macrophage. Let's say that you have a staph that maybe hypotechoic acid may be recognized by toll-like receptor 2 on the surface of the macrophage, or Pseudomonas LPS is going to be recognized by toll-like receptor 4. And so now the macrophage is going to be activated and is going to produce a lot of pro-inflammatory cytokine like IL-1 and TNF. And those cytokines are going to have impact at a different level. So it's going to, first of all, well, let's talk about the migration first. So it's going to have an impact on the endothelial cells, and mast cells also. Sorry, mast cells are also going to start producing, like Dr. Fernandez was telling you, histamine and prostaglandin as well. So that's going to start the process of vasodilatation of the vessel. So now you get the junction between the epithelial cells that loosen. And then also, more importantly, the IL-1 and TNF are going to upregulate E-selectin and P-selectin on the surface of the endothelial cells. They are going to upregulate VCAM1 and ICAM1, which are the integrin ligand. The integrin, again, that have receptor on the surface of leukocyte, neutrophil, and monocyte. Chemokine also are going to be produced by the macrophage, which are going to bind on the surface of the endothelial cells. Okay. And so what happens, you have your leukocyte, and remember the neutrophil are the first one that are going to get to the site, leukocyte and monocyte that are flowing into the vessel. And then now they have receptor on their surface that are going to bind to the E-selectin and P-selectin, and they are going to work, but those adhesions are not very high affinity, so they are going to attach and detach, and that's why it's rolling. Okay. Then, with the chemokine that is bound on the surface of the endothelial cells, now the chemokine receptor on the surface of the leukocyte is going to be engaged, and that's going to lead to the activation of the LFR1, for example, on the surface of the neutrophil. And now it's a high affinity LFR1 that is going to be able to bind to ICAM1 on the surface of the endothelial cells. And so now the adhesion is going to be very tight. And so the neutrophil is going to stop on the surface of the endothelial cells. There is going to be a cytoskeleton rearrangement, and then it's going to be able to squeeze between epithelial cells and follow the gradient of chemokine. And of course, during that time, you have all of your bacteria that are dividing because they divide very quickly, like every 2 hours.
20 minutes.
20 minutes. So remember, it's really a race. You want to control the bacteria, you know. So you want as many of neutrophil to get there to be able to phagocyte the bacteria and kill it. At the same time, those cytokines are going to have an impact on the brain and are going to induce fever, and you want that, so like that's going to inhibit replication of the bacteria and the viruses. It's going to have an impact on the liver, and remember you have those CRP, SAP, and NBL that are going to be produced and can opsonize the bacteria, so they are going to recirculate and get into the tissue and be able to opsonize, bind on the surface of the bacteria, complement. Remember, actually, when the vasodilatation brings the neutrophil in, it's also going to bring all of those plasma proteins, which include also the complement. And complement also is going to be activated on the surface of the bacteria. And C3b is going to be released, and it's going also to be able to bind to a lot of bacteria, so you get a lot of opsonization again. It's also going to be able, so this is a schematic of what happened there. You have binding of C3b on the surface of the bug, binding of SAP, for example, on the surface of the bug, and all of this induce phagocytosis, and remember, and also more complement activation by the SAP, not the one that is bound, but and then you also have an impact of the cytokine on the bone marrow over there to bring more neutrophil. Okay. So then you get also complement activation is also going to lead to more C3A and C5A release, which again are going to recruit more leukocytes. So you can see it's a very big amplification cascade of events.
Yeah, just one.
Go ahead.
Okay. Yeah, Dr. Allard mentioned this is a very constantly amplifying system. So don't think this is like a one and done action like certain basketball team. But sorry, not with respect to the UK. I don't see any UK teachers. Okay, not with respect. No, so for example, mast cells are going to produce histamine and start making prostaglandins and leukotrienes. When all these leukocytes come here, they're still going to be making more prostaglandins and leukotrienes and attracting more leukocytes. So I guess it's a constantly amplifying process. And we didn't mention leukotrienes here, but the main source is going to be all those leukocytes that are going to come to the inflammation side. And the other thing, we talk about some of the clinical laboratory tests. So what do you think, if you analyze the blood of this patient, what would be different compared to a normal? Yeah, so it's probably going to be leukocytosis, right? Because of these cytokines acting on the bone marrow, attracting more. What type of leukocytes? Especially neutrophils, so we probably have neutrophilia. And maybe also some of the plasma proteins are going to be altered. Some of these C-reactive protein and an acute phase, all of the acute phase proteins.
Okay, so, and I don't need a microphone. So, this is all going on, and of course, there are dendritic cells that are also in the tissue, right, in the dermis, the epidermis. And the microbes are there. The dendritic cells will pick up the microbes. They'll become activated with the same molecules that activate the macrophages and all of the same sorts of things that both Dr. Allard and Dr. Fernandez talked about will also activate the resident dendritic cells. And what do when they become activated? They pick up parts of microbes. Yes, right, but do they stay there? Okay, so this is going to take some hours. So this is all happening immediately because you have to hold the bacteria at bay. But the next step is to induce the adaptive immune response, because all this does is keep them in check. It doesn't eliminate them. The adaptive immune response is responsible for ultimately clearing the infection. So you have to kick that in. That has to kick in. So those activated dendritic cells with bits and pieces of the microbes, as well as bits and pieces of microbes themselves, will then hop into the local lymphatic vessel, which drains into the local lymph node, right? And there it starts the whole process of activating T cells, okay? And Dr. Mitchell will now, but remember at the same time that, so where did those T cells and B cells come from? Bone marrow, right? Well, where do the T cells come from? Right. So they're always newly entering into the lymph nodes, right? So you always have recycling of naive B cells and T cells in the lymph nodes waiting to encounter their antigen. That's happening all the time, all the time. This takes probably maybe a day to get those loaded dendritic cells into the lymph nodes. So in the meantime, you have to hold those bacteria in check. And Dr. Miller would like to talk about the bacteria. Yeah.
I just want to remind you of the dynamic process taking place, how dynamic it is. So when the wound takes place, obviously that's an advantage to the host because the inflammation takes place initially based on the wound, not the microbes that are there, right? So as the microbes start growing, the inflammation has already started. the compromising event to a wound is that what they've been telling you here is the normal vascular supply. Remember, a wound is going to give you a lot of dead tissue at the site of the wound. So what does dead tissue have? It has no vascular supply. So this balance going on between the microbes growing in the dead tissue and amplifying with the vascular supply and the inflammation taking place around it. And so if the microbes, it's a race to see if the microbes can grow faster than the immune response can penetrate that dead tissue and compromise it. And what happens if this doesn't work right is you get an abscess formed at the site of the wound. So as we go on, you're going to be looking at sepsis and stuff in the next couple of weeks taking place. But nevertheless, it's this race going on. So what they're showing you is a normal vascular supply to this. Remember, there's dead tissue there. So I just want to point that out. Dead tissue doesn't have a vascular supply. And that's an advantage to the microbe. Because microbes grow in dead tissue. Remember, they're facultative or anaerobic organisms. They can grow in dead tissue, this as well. So vascular supply doesn't have a good inflammatory response because of the blood vessels are not in the dead tissue. So just want to point that out.
All right. So the starting point for this bit of the story is naive cells have previously seeded the lymph node that drains this site. Every site in our bodies has some lymph node that will drain it. So there are, if you look here, there are follicles in lymph nodes that are B cell rich. The T cell zones are here. They're separated. They will have come from the generative organs, of course. Dr. Miller just mentioned that dead cell tissue, debris, and bacteria will be coming down. So this is a great example of why you need to have cleansed the T cell repertoire of self-reactive T cells, right? Because that's an opportunity then that they might have thought was a microbial invasion if a cell had its receptor be specific for self-protein. So that won't happen. Instead, there's going to be a very rare 1 in 100,000 T cells that can respond to any one of the proteins in the bacterium. There will be multiple T cell clones because there are so many proteins in the bacterium. And the same is true for the B cell. All right, so you have this very wide number of random antigen receptors generated randomly with respect to what they're going to bind, except that they're cleansed of anything self-reactive. So in terms of the time course, with vascular pressure increase, there's more fluid flow to the lymphatic. Some of the first stuff to get there is probably bacterial debris, metabolites, and such. So there's an opportunity for the B cells to be triggered via their BCR to become activated and start to divide. It takes them some time. Eukaryotic cells take a lot longer to divide. It's at least 3 days before a B cell can really get its act together and start to undergo division. Then it will start dividing. Concurrently, as this dendritic cell picks up debris and travels down and matures, it gains expression of more class II. It loses its ability to pick up material. It has it in the wound site, but it loses the ability to pick up new material, kind of tones that down, brings up the T cell activating qualities that it has. So there, it needs to get into the T cell area, which it homes to with CCR7, just like the naive T cells first got there with their CCR7. And then there's this process by which the dendritic cell has to find one that is a fit. And that's facilitated by the T cells moving around. So that you're seeing static images, but there'll be a lot of movement of T cells. All the naive T cells are kind of moving around, and they will test. You get these docking events that will only have happened if there was positive selection, so it's a useful T cell. When there's a good fit, then you get information flow from the dendritic cell to the T cell. Number one, the activation, signal 1, signal 2 with co-stimulation through B7 to CD28. You begin to get cell division of the T cells that are appropriate. Some of those may leave the lymph node and circulate so that they're available to help. So now there'll be T effector CD4 helper cells, for example. CD8s would be less relevant here because it's their job is to kill infected cells. So unless these are intracellular pathogens, that won't be as relevant. Some of the T cells will, upon being activated, they lose their CCR7. They don't have any chemoattractant to keep them in the T cell area, they gain the chemoattractant signals that the naive B cells had initially, so they start heading to the B cell zone. B cells have a reciprocal switch. They head toward the T cell zone. And there again, there's a match. You've got to find the B cell that is itself presenting something that it captured through the flow. It needs to present to the T cell. So, okay, say I'm a legitimately specific B cell. T cell says, so am I. Let me tell you what's going on. So the T cell then will instruct the B cell through cytokine messages, just as the dendritic cell has. That is one of the beginnings of the germinal center reaction, where you improve the B cell response, okay? So you have a split point for the B cells. Some of them will go into the germinal center, which I've drawn as an expanded part of the follicle. Other B cells will temporarily make IgMs, some amount of it. They'll be short-lived plasma cells, and they will make and try to start making IgM that can get circulated and may be helpful for the infection. What's the main thing IgM would do at this point? So it gets through circulation, it's circulating, so you end up having serum content of IgM that's specific for the microbe. Complement. So that's the main thing it does. And it's IgM because it's me first, right? So the germinal center, just briefly, is the reaction in which, A, the isotype switch happens. Which one is chosen, it depends on the kind of infection that the DC told the T cell about, and then that the T cell told the B cell about, via cytokines, specific cytokines. So the B cell will be instructed to switch to an IgG, probably, and at the same time, it will start the hyperaffinity maturation process, in which it will start making randomized mutations focused to the CDR antigen binding site, and then go through a competitive process, so that you end up picking out the best winners, the higher affinity antibodies, and it could be a reiterative process. You can have 100 to 1,000-fold increase in affinity, which makes them much more efficient when they get to the mess of the wound, if it's still there, to provide antigen-specific detection of the microbe. So that then can lead to effector functions of the antibodies, which you'll remember, in this case, would mostly be through the FCR. So you would boost the complement activity by now having these laser-guided antibodies that go right to the microbe and light it up for phagocytosis. So that is effectively the same as an innate phagocytic event, but it's a much more efficient one.
Okay, so all of this has been described very elegantly. So now let's talk about the cell-mediated response that Dr. Mitchell already touched upon. So the dendritic cell that was hanging out of the epidermis has been activated by microbes, okay, to move down into the draining lymph node, as we mentioned. So if that dendritic cell has been instructed by the microbe through all the receptors on its surface, TLRs, and all the different receptors that are actually all part of the innate immune response, to produce IL-12, what kind of a T cell are you going to get? Th1. What does Th1 do? What does it produce? Right. And what does gamma interferon do? Okay. Okay. It does activate macrophages. Let's do what's the other thing it does?
Stabilizes the Th1.
Okay. So what does it do from an effector standpoint? You're right. What else does it do? So it activates macrophages. It does something else very important. Right. So it's also involved in antibody production, complement-fixing antibody production, right? Opsonization antibody production. Okay. That's what Dr. Mitchell just mentioned. That switch differentiation into a Th1 occurs in the lymph nodes after encounter of the dendritic cell that's presenting antigen to the naive T cell that is responsive to the particular antigen that dendritic cell is producing. And remember, that dendritic cell is actually presenting a lot of different antigens, so it can actually literally activate a lot of different T cells, okay, all at the same time. But the T cell will only respond to the antigen it's specific for. It will proliferate. It will, and what is the proliferation? What do we call that? Clonal expansion. So only those cells that are responding are going to clonally expand, right? And secondly, it will differentiate, as we mentioned, in response to IL-12 into a gamma interferon producing cell, which then has those two activities. Let's not talk about the activation of macrophages first. And the same cell can do both, okay? The same individual cell can do both, theoretically. So the first thing that the CD4 probably does, as Dr. Mitchell mentioned, it downregulates its chemokine receptor that makes it stay in the T cell zone and heads toward the B cell zone. The B cells start, okay. So the first dance that occurs between these two is that T cell interacts with the B cell that's expressing and presenting the same antigen, right? Okay, so the T cell now knows that this is where we need to be producing the gamma interferon, and that's when you get differentiation into a B cell that's producing an IgG, a complement-fixing IgG. Okay, and that's what Dr. Mitchell had just said. That's a Th1 cell will do that, and we can talk about Th2 cells in a second. Okay, so that happens, and it's actually quite complicated, much more complicated than we're telling you. The other thing that can happen, that same T cell or another T cell that's been activated similarly can hop into, how does it get out of the lymph node? The efferent lymphatic vessel, right? So it gets out of the lymph node through the efferent lymphatic vessel. So it downregulates all those things that keep it in the lymph node. Leaves, the effector cell now is different. It is now primed to be producing gamma interferon. It jumps into the efferent lymphatic vessel, which ultimately dumps into the major lymphatic vessels, thoracic, okay. That then dumps into the venous system, okay? So you'll always have circulation anyway of the naive cells. In this case, that circulation is important to jump into the bloodstream because why? It needs to get to the site of inflammation, right? So it goes to the site of inflammation. It arrives there. It is now expressing, because it's been activated, the adhesion molecules and the chemokine receptors. It needs to be able to identify, which are very similar to the ones that the neutrophils and the other leukocytes express, in order to get through, squeeze through the endothelium, okay? And those T effector cells, these are Th1 cells, enter into the tissue. They then interact with macrophages that have already phagocytosed the microbes there. And those, in many cases, the macrophages just are not, they can get rid of some of those microbes, but they're just not really good. The microbes are proliferating like crazy, okay? They're out of control. That T cell then activates the macrophage to totally kill the microbes that are in the macrophage through a really complicated process as well, which we talked about. Reactive oxygen species, nitric oxide, all of those things that are in that figure that we talked about. So the macrophage is now able to get rid of the microbes that are in there. It also produces cytokines that further amplify this whole inflammatory response. Okay, so remember, this is an indirect response. These Th1 cells have gone back to the site of infection, and they are amplifying the response here and inducing the macrophage, activating the macrophages to kill off the microbes that they've already engulfed. Okay, so they're aiding that whole process. Okay, so in the meantime, the complement fixing, and this is taking days, right? 7, 14, it takes a while to get that adaptive immune response to occur. In the meantime, they've gotten class switching, so the IgG is now going back, and it's aiding, again, the macrophage and the phagocytes, that complement fixing antibody, the opsonizing antibody that the Th1 cells have induced by the B cells, to help these phagocytes pick up even in even a more specific way, because before that phagocytosis was pretty nonspecific. You know, anybody that has complement surface is picking up. Now it's really helping target those microbes by the macrophage and the other phagocytes. Okay, so that's what's occurring in a Th1 response. Only if that pathogen has elicited that kind of response. And then a Th2 response, we don't need to go into detail, but what is driving, so in case, and this is not going to happen exactly the same way, what's driving the differentiation of a Th2 cell? IL-4. So IL-4 would have to be in this environment in order to get a Th2 cell response. And that's an entirely different response that is too complicated. This is an inflammatory response that we're talking about here. A Th2 response is a non-inflammatory response that's protected, but it's not inflammatory, not considered inflammatory, okay? It's still protective, but it doesn't create this kind of inflammation, okay? IL-17 is yet another issue, okay? And in any case, you're probably going to you're going to have a predominance of one of these Th1 versus Th2 versus Th17, but you're probably going to have a mixture, okay? But mostly you have one predominating response, depending on the sort of pathogen that's being elicited. Okay. Do we have anything else? Yeah.
Okay.
Yeah, go ahead.
Yes, please. This will be a hypothetical case, but let's say that this bacteria, then we have mycobacteria there. That's not the normal way you get mycobacteria, but let's say you have mycobacteria there, and all this response is not going to be able to get rid of that mycobacteria. So what do you think would happen in the tissue? What kind of inflammation would we get then?
This happens for long, right?
Yeah. So we get chronic inflammation, and because it's mycobacteria, then we get granulomas, right? Yeah. What cells are in the granuloma? So the main cells are activated macrophages that take this epithelial shape. What is activating those macrophages? Yeah, the concept said is a Th1 response, or interferon gamma is what is activating those. So in the granuloma, you're going to have these activated macrophages. What other types of cells are you going to have in the granulomas? So I'm going to have the Langerhans cells. These are the multinucleated. These are made by the fusion of these activated macrophages. And what about the surrounding of the granuloma? So more monocytes and especially lymphocytes, these Th1 cells activating the macrophages. And last point, in the middle, what might we have in the middle of the granuloma? Yeah, so it's going to be necrosis, right? So remember, especially for mycobacteria, they have necrosis in the middle and the giant cells and the activated macrophages. Yeah.
It says that interferon gamma specifically is what makes macrophages become granulomatous macrophages, and I wasn't sure how it differentiates, because I interferon gamma and the Th1 pathways just
Yeah.
activate. So I don't know how you kind of differentiate between when it becomes a granulomatous macrophage and when it doesn't.
I think it depends a lot on the chronic inflammation and the stimulus still being present there. And what the macrophages in that case, this is a long-term chronic inflammation. So all this constant interferon gamma activity is going to activate those, but they're going to stay there. In some other infections, it's not that chronic, so you're not going to have like this granulomatous inflammation for staph or other bacteria.
So anything that's not cleared effectively, and these pathogens have, and Dr. Miller can speak to that, these pathogens have, sorry, if you don't mind,
Yeah, that's,
have evolved to not be cleared. You know, they have mechanisms that allow them not to be cleared. That will happen with talc or asbestos or silica. Anything that can't be cleared well can elicit a chronic inflammatory response that can create granulomas. So this is, it doesn't happen with everything, it just happens with stuff that can't be cleared well, okay, right? Is that,
Yeah.
okay, just wanted to. And the other thing, okay, so remember, while all of this is going on, adaptive immune response, theoretically, if you have the same antigen, the next time you get the same infection, if you don't have, and I'll talk to you about that in a minute. So what happens, why is it that bacteria and viruses, we are immunized against them, and yet the next time we see them, there's an issue? Right? Okay, so let's say that antigenic variation doesn't occur. So when you re-encounter whatever microbe this is, how are you going to respond to that? Better, quicker, yeah, I mean, all that stuff, right? It's going to be really, really quick because you have, what is that called?
Memory.
A memory response, right? So in this whole process here, what's going on is you're going to develop not only effector T cells and effector B cells that are producing plasma, that are producing immunoglobulin, you're also going to develop memory T cells, right? Those memory T cells, and we're not exactly sure how they're induced, but they then go back to the original tissue and they just hang out there, right? Or they go to lymph nodes and they just hang out there. They're waiting. And they've already been instructed about what to do. They've got a high affinity, etc. So Dr. Mitchell will talk to you. Oh, do you need to say
That was it.
Oh, that was it? Sorry. Did I steal your question? I'm so sorry.
Just one point added for emphasis about immunity at this point is that the B cell immunoglobulin is the master of the response at that point, largely through the incredibly high affinity and specificity the antibodies will have. So in the full serum content, there will be an amount of really, really specific IgG that helps with rapid on, slow off rates. It means you have to have less bulk IgG with that specificity in circulation to be effective. That's important because we can only circulate so much antibody, all right? So that's why affinity can help be very important. And the other thing to remember is that B cells don't go to infection sites. There may be T-resident memory cells that are in that area. The B cells are the long-range bombers, all right? They have heat or laser-guided missiles. The memory cells for the B cells go back to the bone marrow. And they sit there and they just kind of steadily make the antibody that they were found to have been useful to make. So that's how it gets to the circulation.
How do the memory cells know where to go? You don't know. They express receptors that they've been turned on at a certain area. So, for example, T cells that have been in lymph nodes that drain skin upregulate molecules on their surface that allow them to then go back to skin. Remember, they're going to dump out of the lymph node, then they're going to go in circulation, they're going to go back to the site, right? The same is true for gut-specific memory cells. These are T cells that we're talking about. Okay, does anybody have anything else to add? Dr. Miller? So what's happened to the microbes at this point?
They're all dead.
Okay, we've killed the microbes, right? Right. Okay, so yes.
Unless there's an abscess,
So,
then,
yeah, the floor is open to questions now. Yes.
What you just said about B cells not leaving, but B cells,
B cells don't go to the infection site, so they're not foot soldiers. They can take up antigen. They are not phagocytic cells. Anything they take up to present is through their antibody. So the BCR, when it's in its membrane-bound form, if it captures an antigen or a protein, it can pull that in, and that's how it processes. But not for initial T cell activation. So that's to get instruction from a T cell.
So is that clear to everybody? Okay, so not that you didn't explain it.
Yeah.
So
What the
that's
question?
only happening in the lymph node?
Yes, that's the primary place it would happen.
Where
Correct.
does it get the antigen?
That's through the fluid flow.
So it has to be in the bloodstream?
no.
Lymphatic.
I mean,
Right. So in addition to the fluid, the bloodstream, and all the vasculature of the cardiac system, there is a whole separate sewer system that is the lymphatic. So it's always it's always sprinkling, there's always fluid coming through. When there's an infection, there's a shitstorm. There's a lot of sewage coming through, right? And that's part of the alarm. That's why that's an alert for the command and control center to respond. So the B cells are there. And remember, it's because they're so rare. You want to organize all the diversity so that you can more efficiently find the one that's right. So
Yeah,
the point about the B cells is they just don't circulate back to sites of infection. They are not ground soldier effector cells.
Yeah, remember what the lymphatics do, right? The lymphatics drain every tissue in the body. They drain the lymph, so you have the bloodstream all over the place, you have nutrients, you have fluids that are getting into the tissues, and then the lymph, it has to go somewhere. It doesn't go back into the blood directly. It's drained by the lymphatics. So the lymphatics drain what's called lymph, and in that lymph, as an infection site, is going to be all the debris and all the caca that is in that infection site, okay? All of that is going to end up in the draining lymph nodes. We just talk about the dendritic cells, but as Dr. Mitchell mentioned, everything that's at that site is going to end up in the draining lymph nodes, including all the bits and pieces of microbes, including, unfortunately, sometimes the microbes themselves. which can cause dissemination, all those sorts of problems. So just always keep in mind. So this is what you need to be doing as you're going through all this. The big picture. What do the lymphatics do? What are they draining? What's going on? The whole thing. Ask yourself questions. Do I know what the next step is? Do I know what cells are involved? Do I know what molecules are involved?
Whenever you were talking about the germinal center,
Not me.
or somebody, the T and B cell interaction. Did you say that the T cell becomes a B cell, or
No.
what was that? How did you get from the T cell and then the B cell making the E?
So the T cell, you have to have one antigen-specific B
You
cell,
wanna
find
draw?
an antigen-specific T cell, and they get together and form a conjugate.
Yes.
And the instruction is the T cell to the B cell. That's maybe what you know.
Okay.
It's information flow to the B cell.
And that tells the B cell to start producing antibodies.
Yes, right, and which kind to make, and then it's a signal to go into that germinal center factory and start improving its antibody fit, antigen fit. Question?
So just for like clarification, so when a B cell is instructed on like what kind of antibody to make,
Mhm.
that's like when it becomes a plasma cell? Or,
No, that's an early step. So the plasma cell is a memory cell. Think of that as a very late step.
okay, what about the short term?
The short-term ones, there can be short-lived plasma cells, and they're named plasma cells because they're contributing to plasma content, right? So there could be short-lived plasma cells that make antibody and put it into circulation. The real memory is when you have long-lived plasma cells. But those, you don't want to invest in that until you've gone through all the affinity maturation. So the isotype switching happens early. You go through this iterative step in the germinal center of competing for the best binding antibody producing cell. So then after that, then you get to plasma cell status.
So plasma cell status is when it's like, this is the antibody we want to make, and we're just going to make it.
Yeah, and no one really knows how that ends, but that is the gist of it, yeah.
Okay.
Could I just step in here? So just to reiterate here, remember the dendritic cell and T cell interact, and you have differentiation here. But they're not spewing out a lot of cytokines at that point, right? Because you don't want them to. You don't want them spitting out cytokines that aren't going to have an effect. They then need to go to whatever cell they're going to have an impact on and interact with that cell. In the case of the B cell, they need to be reintroduced to the antigen so that T cell knows to produce the gamma interferon so the B cell is going to respond. Okay? When it goes to the site, it needs to interact with the macrophage that's going to be presenting the antigen again. Because you don't want a T cell out there spitting out a bunch of cytokine all the time. You need a very specific response. So dendritic cell activates the T cell, induces proliferation, differentiation, and then when it goes to actually the cell that it's going to interact with, it needs to be kind of reactivated. So it's actually producing the cytokine there, just for clarification. Sorry. Okay.
When you were over here, you were talking about how the antibodies become more specific and become missile type. I was just wondering, how are they working better? And then you said something about the FC zone changing.
So the FC zone. So the FC is the portion, the stick end of the antibody. That's the isotype switch. So the FC type is determined by what antibody class it switches to.
Oh,
So you can have an IgM specific constant region FC, or you can switch to the IgG form, which will have a different structure and binds and docks with a different FCR. So that might be the FC zone.
Okay, so yeah, so that's changing, and then also the variable zone is changing to be more specific, so both can
Right.
be changing.
Right, and remember, there's no foreknowledge of what is the best antibody to make. It's all trial and error. So in that process, you're focusing the random mutagenesis to the antigen complementarity determining region, the end of the antibody, sprinkling in differences, and then testing which one binds better. And they have to compete in order to succeed in that competition. Yeah.
So where, I think you talked about like different types of B cells, like molecular B cells, marginal, B1.
Yes.
Like where does that, are they already differentiated into that by the time T cells?
So this is all about, these are all follicular B cells, because this is in the follicle. That's why they're named. These are the classical, sophisticated B cells. Then you have the marginal zone, which are primarily in the spleen, actually. The B1Bs, not even sure where they normally are.
Good.
Good. Okay, good. So that's like a primitive, primordial situation. That's perfect. So and they will make IgM. They can also make what are called natural antibodies, where there's this innate to adaptive transitional zone, where you're in between being really innate and really adaptive. They make antibodies that are more often than not specific for microbial chemistry. So there was a question here first. Yeah.
So whenever the antibodies finish competition and we pick the best one, how does the IgG antibodies go to the site of infection and cause phagocytosis?
Plasma.
The plasma.
Think of that. So this is in the lymph node where this is draining where it's going back to circulation eventually. So that's where the initial antibody comes from.
Yeah.
And it gets added to the plasma circulating content.
So then whenever they get to the infection, does the antibody neutralize the microbe and then it's picked up by the macrophage?
Depends what kind. It could do both, I guess. So yeah, so it would bind to the microbe. Bacteria are harder to neutralize, but that's more often something you think of as viral neutralization.
Oh, okay.
Because they have a repeating structure that you can block and they can't bind cells anymore. Bacteria are mostly opsonized with bacteria. I mean
Okay.
with IgG.
Oh,
So that's like the laser. That becomes the laser part of the laser guided, where it lights up the target, and now it's like a neon target to the immune system.
Gotcha. Thank you.
So think of the antibodies just like the cells we talked about that are leaving the lymph node. They need to go into, the larger lymphatic vessels, into the thoracic duct, eventually into the vena cava, into circulation. Everything that leaves the lymph node essentially traverses the same way, travels the same way back to potentially, and with serum antibodies, you just have to have a bunch of it because it doesn't know where to go, right? So it just goes everywhere. So you have to.
You just mentioned something about when the T cells and B cells leave the lymph nodes, they need to lose certain aspects of the expression. Can you talk about that?
Well, it's a little bit about the sophistication of how they know where to go and when. So when a T cell is made and first comes out of the thymus, it has CCR7, and that homes it to the T cell rich area because the ligand for CCR7 is made by the cells in the T cell area. So they're saying, come here, naive T cells, right? So when the T cell is activated, if it is, then one of the outcomes of activation is to downregulate CCR7, and it gains the B cell version, the chemokine receptor that's specific for B cell areas, for the follicle, which is I can never remember. CXCR5.
CXCR5, yeah.
So CCR7 goes down, CXCR5 goes up, and then does that make sense?
And then when they're activated, the T cells are activated. Another thing that they do, in addition to that, eventually, is they upregulate all those molecules that allow them not only to leave the lymph node, but to get into this. Okay, E and P selected ligands. They upregulate LFA1, so that allows them to be able to bind to the ligands that are on the inflamed epithelium. Okay, all that happens. That's all part of the activation process when you get an effector cell. Is they stop looking like a naive cell, they downregulate everything that makes them naive, and they upregulate the molecules that allow them to interact, to go to the B cell site zone, and or to go directly to the inflamed site, which are the integrins and the chemokine receptors.
Was LFA1 an integrin?
Yes,
Okay.
LFA1 is a right? Leukocyte factor 1, yeah. And adhesion molecule, yeah. Mm-hmm.
Question?
Yeah.
Another T cell question. The co-stimulators,
Yes.
can you go over what those are again? I remember there's a B7. Are there other examples of co-stimulators?
Yes, there are a bunch of them. So that's kind of make it into a vague category. So
That we need to know.
yeah. Well, do you want to use checkpoint inhibitors and stuff? You'll learn it later. So the T cell has its defining feature is the TCR, which will receive signal 1 from the MHC and peptide. Then you need signal 2, which is on the T cell CD28 as the receiving end, and on the dendritic cell would be B712, which are also called CD80 and 86 by the CE designations. So those are only offered, those are part of the regulation of when the dendritic cell matures. So that is turned on mostly as a function of the dendritic cell getting activated because it's alerted that there's an infection. So that's one of the regulatory systems used to say it's a legitimate response. This T cell, you're specific for antigen, sure, but you also have to be activated only when there's an infection. So then there are all kinds of other co-stimulatory molecules. There's, 41BBL, 41BB. Okay.
Look at them, they're like glazed.
Yeah, yeah.
What? Yeah.
So
But
I would
there are
think-
many others, but that's
So
the
that's
big
probably
one.
why I said
That's
co-stimulators.
the biggest, but that's
right?
the biggest one. That's the one.
Following that, I have written down CTLA4 for making it all go away.
Yes.
We're going to talk about that in a couple weeks. Don't worry about that now.
You talk about it.
Yes, the intolerance. Yeah. Sorry?
It isn't real cells.
Yeah, it's upregulated cells, right? It shuts them down.
Yeah, that's the
Yeah, and it does shut, signaling through CTLA4 does shut cells down, but yeah. It's not an activator, it's an inhibitor.
Naive T cells have to be activated in the lymph node.
Yes.
So does that mean that if an antigen, so what role does like the spleen play in the activation of the
So the spleen is a different organ, okay, and it's responsive to bloodborne pathogens. Not all pathogens are going to end up bloodborne unless it goes I guess anything can go septic. Is that correct, Dr. Miller? Yes, but there are many that are bloodborne, and maybe can you just tell us a little bit? So it's specific for a specific kind of pathogen. So it's in blood, so it actually filters blood. So it's got to be a bloodborne pathogen. That is not part of the lymphatic system. So it's not draining tissues, although you might have some. In order to get into the blood, it had to go through tissues, and it is in the draining lymph node. But the spleen has a big component. I mean, that's what it does. It gets rid of old red blood cells, and it takes care of encapsulated, polysaccharide encapsulated bacteria, of which there are numerous types, right? So that's its job. And it does it in a very, very similar way to the lymph node, except it produces even more antibody. So it's a big antibody producer.
So the spleen is the other place where naive T cells can get activated the first time.
Yeah. See, that was the question.
Sorry.
Yes?
Do the antibodies get from the blood to the injury the same way the T cells do?
Yes. Yeah, they just slough through the lymphatic vessels. So that's the only way that
You mean to get out of the lymph node or back at the site of
From the
infection?
blood to the site of injury.
You mean through the endothelium?
Right, it's the same.
Well, what happens here is that inflammation. So what happens here is that the endothelium becomes more permeable in inflammation, and that allows blood proteins, including immunoglobulins, in. So it goes through, right? Go ahead.
Sorry, if I
Go
can-
ahead. No, go, please.
Yeah, that's the purpose of inflammation, to get blood proteins to the site, so you have increased permeability. That's the
So they don't have to adhere to the.
No, they
so
just
that's how they just go through.
endothelial cells kind of become separated, and just plasma proteins just go out from there.
Where does like the CD40
That's one of the signals that is critically important to start the germinal center reaction. It's really important for T cell, B cell docking, and then for that to be an amplified interaction. One outcome of which is to start the germinal center. So when you have defects in it, you never switch away from IgM, so you have this hyper IgM syndrome,
And the other
which
thing,
is rare.
sorry. The other thing it does is it amplifies T cell activation. That whole dance between
Yeah.
the dendritic cells,
That's a
right?
good
So
cell.
you have the T cell and the dendritic cell, and you have the TCR, as Dr. Mitchell said, and co-stimulation through CD28 and B7. That activates the T cell to do its thing. But then the T cell is expressing CD40 ligand, which happens, it's upregulated when it becomes activated, that then activates the dendritic cell that's expressing CD40, that then gets even better at activating the T cell. So it's also involved in amplification of this whole activation of the naive T cell. It's involved in a lot of different places. Okay, so those are the two biggies. Certainly, it's really required for germinal center development. Go ahead.
Yeah. But the gentleman behind you.
Is that also the situation with T cells going back to the site of infection and activating macrophages?
Yes, yes, yes. It's
Great.
also involved there, right, that's right. It's also involved in this whole dance as well, everything. So it's involved at almost every level, but it's an amplifying event, basically.
So in the germinal center reaction, if you had a deficiency in CD40, does that block isotype switching or affinity maturation or both?
Both.
Both.
Hyper IgM. So you don't switch away from IgM, you just keep making IgM. Well, and the T cell point that Dr. Kozowicz made is excellent. Does that defect, if that step is defective, does that reinforce hyper IgM? Yes, because you are preventing the T helper from getting activated, so it can never give help to the B cell to switch from IgM.
Can you repeat that?
Yeah, so the very last part.
The deficiency.
Okay, so the deficiency in CD40 and CD40 ligand that underlies hyper IgM syndrome can happen and does happen in two ways. One is the B cell doesn't get immediate help from the T cell. That interaction is defective. So the B cell docking to the T cell can happen, but it's not strong. It's not reinforced by CD40 ligand signaling. Upstream of that, the same problem exists with the T cell docking with the dendritic cell. So you don't have very good activation of the T cell to begin with.
You get some activation, but it's not amplified enough to, you need full activation, which you require the CD40 signaling.
And remember, it's a syndrome. There are other things that go wrong. So that's why the other functions of CD40 ligand would also be a problem for those patients.
Right. So, and you can have mutations in both CD40 as well as CD40 ligand and hyper, as Dr. Mitchell mentioned, hyper IgM syndrome. Okay. So, yes.
So kind of going off of that, this is for Dr. Mitchell. So would you say that your study questions then are a good reflection of what we need to take away from your lectures?
Yeah, that's the level of detail I'm looking for. It doesn't have all the content because and speaking of those, I have I'll post the answer versions now, and then I'm going to turn some of those into practice exam types, which we learned we need to give. So you can have the A through E choices. Just one thing about the way I write questions, what I try to do is not have incorrect statements as one of the choices. It may be true, but it isn't the explanation, because I don't like writing inaccurate things. And I don't want you to say, you see something that is stated as fact when it's the incorrect answer because it's incorrect. I don't like to do that. I can't always avoid that, but most of the statements should be true, but only one will be the most relevant. And I'll give you an example of that in the practice question.
Okay, so we're going to start with the quiz. If you have any questions on any of these, we're going to try to do, what is this thing called? Nearpod. If not, we have backup on the good old-fashioned USB. Okay, so that's your code. Yes.
Are these different practice questions that we've already had, or are they
No, they're the same ones you've had.
Okay.
Yeah, so we're just going to go over if there are any issues. I know mine were very easy. So we're going to go over the answers. Okay, so are you ready to?
Yes.
Are you ready to go?
Yes, so this is the integrity of the excellent. Yeah.
Some of that I've already listened to before.
Yeah.
I don't have the answers. The answers, I don't have the multiple choice up here. This is really a silly system, I think. Which cell is the most effective at initiating adaptive immune response by activating naive T cells? Can you do your thing there, whatever that is? The problem is, that's not helpful, not to, because I want to go over why, if people have questions about why the wrong answers are wrong.
That's why you need to.
Okay, I'm doing the, never mind, I'm doing the, that's really silly.
Yeah.
Who decided to do this system? It worked fine as iClicker, I don't get it. Anyway, because I want to talk to you about what the, okay. So what is the most effective at initiating the adaptive immune response by activating naive T cells? Is it A? Yes. So it's not eosinophils, it's not immature B cells, right? They're not particularly good. It's not mast cells, not monocytes. Okay. The cells most likely to be lysed when treated with anti-CD4 antibody and complement are what?
D helper.
Okay, it's the D helper cells. So you had to know that the helper cells are almost exclusively CD4. So if you lyse a cell that's CD4 positive, then you're going to get rid of the T helper cells, right? Are there any questions about that? Okay. This is a little wordy. An antibody made against a large protein antigen reacts with it even when the protein is denatured by disrupting all the disulfide bonds. A second antibody made against the antigen fails to react when the antigen is similarly denatured. Which of the following is the most likely explanation?
B.
Why?
Because antibodies can recognize different components.
Right. So, in the case where the antibody is recognizing the conformation of a blob of protein that's together with secondary, tertiary structure, it's going to be different. Remember, there's that's in the online PowerPoint and handouts. If it's been denatured, you're going to lose that reactivity. However, if you're only binding, the antibody's only binding to a linear sequence of amino acids, it doesn't matter if it's been denatured. As long as it's been exposed to the outside, you'll still have the same antibody. The antibody will be specific. Okay? Okay. Which of the following cytokines is the mediator of Th1 responses? Interferon. That was very straightforward. In which organ do T cells provide help to B cells?
Lymph nodes.
Right. What's the other organ? Spleen. Right. Which of the following induces Th1 differentiation? IL-12. The cytokine that plays a central role in differentiation of Th2 lymphocytes? IL-4. The most abundant antibody isotype in the GI tract?
IgA.
Okay, and why is that? Because it's secretory. Which of the following cannot function as an antigen?
We debated this one because we didn't know the answers.
Sorry?
It's either with the people I went over with, we either had metals or E. So we didn't know if metals qualified. The other three did.
Anybody have allergy to jewelry?
Okay, so
Okay, if you do, that means your jewelry has a significant amount of nickel. So if you thought you were paying for 18 karat gold, it wasn't happening. Okay. So, and if you have an allergy to jewelry, it's almost exclusively against nickel, so you can have an allergic response. And what is the nickel? So what is that whole response? So, what is that an example of? Haptids. Nickel metals are a haptid. Okay, they act as a haptid response. Okay. A little different from other ones. So the correct answer was E, all of the above. Yeah.
So DNA then
Absolutely. So we're going to learn in lupus. The problem with lupus is you have a lot of antibodies produced against DNA, RNA, histones, all of those things. So certainly any molecule can be an antigen. Yes?
So you're including metals as haptens as the umbrella of all
that can be an antigen. Anything can be an antigen, essentially, anything. Go ahead.
So a hapten is an antigen? Like,
a hapten is an antigen, but it's an antigen that cannot elicit a response by itself. It has to bind to a carrier protein. Dr. Mitchell mentioned that already. We're going to go back to that because it's very important for contact hypersensitivity, because poison ivy is through a hapten and a carrier protein. It cannot elicit a response directly by a T cell. Okay? Why? Why can't you get a direct? There's some evidence that there might be something weird going on, but just for the sake of argument. So why can't a hapten, like metal, for example? It's not a protein. T cells can only respond to peptides that are presented on class 1 or class 2 molecules. That's right. So it cannot respond to that. The B cell can. It's complicated. So it will respond to the carrier protein, right? And the carrier protein, yes, go ahead.
I was going to say, what would be an example of a carrier protein? Like, does it bind to
Albumins.
a plasma protein?
Yeah, yes. Which then the question becomes, why aren't they tolerant to those proteins? And I think it's primarily because those haptens can modify the proteins to make them antigenic. Okay. So yeah, there are lots of different proteins. There are proteins in real life. Penicillin is a big one, is a hapten, and could create big problems for penicillin allergies, which can have 2 different outcomes that we're going to talk about. So there are a lot of hapten-related pathologies, which is why haptens are important. Okay? Okay. Which of the following is the most effective protection against microorganisms? Right. Why? I mean, they're everywhere, right?
Yeah.
Bugs are everywhere, and you're completely encased in epithelium. You know, if that breaks down, you're a big doo-doo. So that's by far the most effective prevention of, okay? Which of the following is a feature of adaptive immunity that's important for long-term immunity against a primary infection or vaccination? Memory. So it's not diversity, because you have diversity. You know, that's important for an immune response in general. Specialization, same thing. It's important for an immune response. There are specific immune responses like Th1 to get rid of intracellular bacteria, etc. Contraction and homeostasis, same thing. You just need to get rid of all those excess cells so you don't become a gigantic lymph node. And non-reactivity to yourself, that's a primary immune response issue as well, so it's memory. Okay, which antibody isotype is transmitted across the placenta? Board question for sure. Okay. Oh, it's B. I mean C, rather. Sorry, it's IgG. Okay. You see that all the time in various permutations. Which of the following is not a phagocyte?
Natural killer cell.
Natural killer cells. All of these others are classified as phagocytes. They can all phagocytose microbes or parts of microbes. Okay. Which organ is important for elimination of polysaccharide encapsulated bacteria? The spleen. We talked about that. Blood-borne pathogens. So, and Dr. Miller is going to talk about that in probably great detail in the future. So spleen is the important organ for that. Why is it important for naive T cells to express the chemokine receptor CCR7? Is it because it allows them to enter the site of infection and attack the pathogen? Does it allow it to escape the bone marrow, as far as you know? Does it allow it to migrate out of the efferent lymphatic vessel? A little unsure about that one. Does it allow it to enter the thoracic duct and subclavian vein? Does it allow it to enter the lymph nodes through the high endothelial vessels? Yes. Right, so that's the chemokine receptor that a naive T cell will upregulate. Okay. How many peptide or polypeptide chains does an IgG antibody have? 4. What are they? Right. Too light, too heavy.
I have a question for 50. Would C be correct if it was asking why it's important for naive or for T cells to downregulate CCR7?
That's correct. That would be part of the, yes. Okay. So Dr. Allard will now
I have a wait.
Yep, go
For
ahead.
16, because it was IgG, so a single antibody has 4, but like for IgM, because it can form pentamers, is that like 5 different?
Depends on how it's asked.
Okay.
So, yes, that's why I didn't ask IgM, because it's difficult to ask that to get the answer that you want without being confusing, right? Okay, where is this? So Dr. Allard requested me to read these. A baby within, I'm sure my voice is very annoying, but a baby within the first few months of life presents with recurrent bacterial infections that involve the skin, the umbilical cord stump, soft tissues, lungs, and deep organs. A complete blood count is performed that reveals a severe immune deficit, which innate cell type deficit was identified.
Not often, yes. Because remember, they are the first one that are going to be very important to get to the side.
Does everybody
Agree with that? And I have very long questions.
And also, it's written in French English. I did try to do it, but she does a good job. A patient comes to the clinic complaining of severe pain in his big toe. Upon examination of the toe, which presents signs of inflammation, the family, she never puts S's. Anyway, the family's susceptibility and the fact that no injury to the toe had occurred, the doctor concludes that it must be gout, i.e. accumulation of monosodium urate crystals in the joint. Genetic analysis of the patient further identified mutations in NLRP3, which results in its spontaneous oligomerization. Furthermore, the patients present with cardiovascular disease, which precludes him from receiving the current common treatments. What is the most specific and adaptive treatment that the doctor should prescribe? Well, that was complicated.
So what do you think it is?
C.
B.
B. So you remember what the NLRP3 inflammasome are? So there are NLRP3, which is going to recognize the bug. Then you have the caspase 1 and the adapter molecule. So that's why, in this case, obviously the non-specific treatment will be the corticosteroid and the non-steroid anti-inflammatory drugs. And unfortunately for gout, a lot of people cannot take that, especially if you have a cardiovascular problem, but also a lot of people are not responding to those treatments. And so remember the NLRP3 inflammasome, what does that lead to once it's activated? You remember? I know that I was trying to ask questions on stuff that were not necessarily something I was going to ask, to ask you a question during the exam, but just to show you what the format will be. Remember, NLRP3 inflammasome leads to IL-1 being produced, IL-1 beta. So in this case, the IL-1 beta antagonist will be the right choice. Caspase-3 inhibitor will not do anything because caspase-3 is not involved in the oligomerization. And anti-IL-6 antibody will not do anything because you are not getting IL-6 being produced. So the problem there is a lot of IL-1 being produced, and causing the problem. So you want. So you could use an antagonist. You could use an inhibitor. You may be able to use also antibody blocking the IL-1 receptor. So those are all actually the new drugs that they are trying for gout right now.
And this is a very good example about why it's helpful for you to know the mechanisms underlying some of these disease processes, right?
Yeah, so in this case, you need to know that IL-6 is not being invoked, so that tells you that it's not the right answer, for example.
So don't let the drug rep sell you an anti-IL-6 to treat your gout patients with gout, okay? Okay. Dendritic cell's major function is to link the innate and adaptive immunity by migrating to the lymph node and presenting microantigens picked up in the tissue to the T cells. They also provide the required additional second signal that will allow T cells to proliferate and differentiate. In the case of an extracellular bacterial infection, which second signal will induce Th17 differentiation?
Which one is it? IL-6.
And we learned about that yesterday, right?
So remember, B7 will be part, that will be a costimulatory molecule, but that will not be, of course it's going to be necessary for all type of interaction, so not necessarily Th17. IL-12 will give you what? What type of response? Th1. Obviously CCR7,
So would TGF beta also be a right answer here?
That will be, but
Okay.
I didn't put
But
it.
just in the context.
Well,
Yes.
actually,
Would you have to put it with
you will have to have IL-6.
Yes.
Okay.
Yes.
So both
Good.
of them.
Good.
Good.
Okay, you have a couple questions out. I see hands.
Sure.
Are there CCR settings on dendritic cells? Or are those just on?
Yes, yes.
There are.
So actually, for example, if you look at the epidermis, where there is a lot of dendritic cells, if they stain the tissues, they will have downregulated CCR7. As soon as they, for example, if there is a bacterial infection, they are going to be active. They are going to mature, and at the same time, they are going to upregulate CCR7 to leave the tissue and go to the lymph nodes.
Yep. All cells have chemokine receptors because chemokines are what are produced at sites of inflammation, lymph nodes. They're the ones that tell the cells
Where to go?
Yeah, so they go down like a chemical gradient in the blood, right? And they kind of find their way there that way. So they all have chemokine receptors, okay? Different kinds, depending on where they need to go. A patient is diagnosed with recurrent Neisseria meningitidis. Did we miss a couple letters there? The doctor suspects a complement deficiency and tests the ability of the patient blood to perform complement-mediated hemolysis, CH50, as well as to induce C3b deposition. The CH50 is abnormal while C3b deposition is normal. Which step of the complement or molecule involved in the complement cascade is not functioning properly? I'm not sure I read that very well. Nice.
So I wanted to ask you two questions about the complement. So which one do you think is correct?
B.
So why is it not an A, for example?
Because we already have CGD.
Yes, so they already have it. Why not a deficiency in factor D, H, or I? And so obviously those are the inhibitor, except for factor D. So yes, so the point is, remember, Neisseria is one type of bacteria that is very susceptible to the membrane attack complex, lysis. So obviously, in this case, you really want to have C9 to polymerize. If you don't have polymerization of C9, you will not have any MAC being formed, and so there will be no lysis of the bacteria.
Complement activation can be initiated in 3 ways, including binding of C3b on microbial surface, alternative pathway, binding of C1 to microbial antigen-bound IgG, IgM, or microbe-bound SAP, CRP classical pathway, and binding of mannose binding lectin to mannose on microbial surface, this is the lectin pathway. What is the major function of the complement system that leads to phagocytosis of microbes?
D.
D.
Oh, D.
D. D. So we have many different answers. So in this case, we are talking about phagocytosis. So what leads to phagocytosis? Opsonization. So obviously that's why that would be D, because you want opsonization with the opsonin C3b. Of course, you are going to have release of the anaphylatoxin, but that's not involving phagocytosis directly. It's involved in the recruitment of the leukocyte at the site of inflammation. Normal attack complex has nothing to do with phagocytosis. Increased micromedicinal activity of phagocyte, it would play an important role in the killing of the bacteria, but not in the phagocytosis. And I guess in this case, IgG is an opsonin, but it has nothing to do with the complement system being involved in phagocytosis. So.
Phagocytosis of microbes by macrophages results in its killing. What are the molecules that mediate the killing of microbes once fusion of phagosome with the lysosome occurs?
That was an easy one.
I didn't hear them say that. You said it. Did they say it?
Okay. So reactive oxygen species. Obviously, phagocyte oxidase system and enzyme nitric oxide centers are going to be important for the formation of those toxic substance, but it's not going to mediate the killing directly. NADPH is going to be a cofactor of the INOS, so it's going to play an important role, but not, again, directly. And then the major basic protein is the one that is released by the eosinophil, so that's not information. So I guess, are you getting a sense?
If you had NADPH oxidase up there, then which one is more correct? Because like from papilloma, NADPH oxidase deficiency leads to like that disease where you have messed up oxygen-dependent killing.
Well, in this.
I'm guessing
Sure, no, I know. So that's why right now, yeah, okay. So in this case, that would be, it's a cofactor also for the inducive nitric oxide center. So you need it to get nitric oxide to be released, which is going to contribute to the killing of the bacteria. But that's not going to mediate it directly. So that, I guess that would be the correct answer. That's why you really need to look at the question very specifically. Maybe try to underline very specifically, you know, the question. Then you can go back to the question, to the answer, and start eliminating. Sometimes it's very straightforward. Those questions here are more difficult than the one I'm asking you in the exam. So I just wanted to tell you that. Those are, however, I think are more similar to the one you get in the board because they have like scenario and stuff like that. So, but yeah.
Sure.
You want to read? There is.
Oh, work. Oh, sorry. I thought you were
Well, you
done.
said Twitter lecture.
That's right. Sorry. Okay. Microbes have evolved to evade the immune response. Which evasion mechanism is used by mycobacteria to avoid to be killed once phagocytosed by the macrophages?
Yeah, so that would be blocking of the fusion of the lysosome with the phagosome. Obviously, resistance to phagocytosis, it's already being phagocytosed, so that could not be there. Granuloma formation, I wanted that there because bacteria will protect themselves by granuloma, but in this case, it's phagocytosed already, so it's already in the macrophage, so it's not going to be able to protect itself. Inhibition of granzyme production, obviously granzyme are being produced by NK cells and cytotoxic T cells, so that will not be the mechanism there. And resistance to MAC lysis, again, that's a complement, so that will not apply.
So in the granuloma, the bacteria is not in the macrophage.
Can be.
But I don't know that.
Yeah, granuloma will be the attempt of the immune system just to keep the mycobacteria confined.
But actually, the bacteria will not be inside the
With the
macrophage.
bacteria, just
Germ-
the macrophage or no?
No, the,
Yeah, the mycobacteria will be there.
So this would be.
So I guess that's,
we know that.
then that could be challenged.
But I guess the
But
question is, what is
no.
keeping the mycobacteria to be killed? So it's not really the granuloma; it's just avoiding the lysosome fusion.
Yeah, the granuloma is the end result of not clearing it. It's not the causative, right?
The immune system is just trying to keep the
So,
mycobacteria
yeah, no, you
there.
couldn't challenge it, well, you could
Right,
challenge
but
it.
I didn't know that which comes first. I thought that maybe the bacteria likes to get into the macrophage and stay there as a granuloma because it's protected. It can't be eaten there.
Yeah.
I mean, it can't be destroyed.
No.
Right?
No.
No.
The granuloma is the consequence of not being able to
Yes,
kill
not
the
be able to be clear, then you will.
So are we expecting to know this level of details, like what the mycobacteria and for the actual test, what with the mycobacteria or other bacteria that you gave as examples?
No.
Okay.
Just general, but you do need to know general classes. Intercellular, extracellular, viral, but not specific bugs yet. You will be introduced to those by Dr. Mill, and then you'll have to know. Okay. Parasites exhibit various differences, including difference in structure, life cycles, pathogenic mechanisms, as well as the mechanisms of protective immunity they induce. Which of the following cells are critically involved in the elimination of intracellular parasites like protozoa, Leishmania major?
So that would be, remember eosinophil, that's for element elimination. So the extracellular parasite. Mast cells will be triggered to the granulate with element as well. Natural killer cells will have no really impact there, or Th2 cells. Again, you don't want the Th2 cells for protozoa because that will inhibit the macrophage activation.
Viruses are obligatory intracellular microorganisms. However, the protective mechanisms they triggered are very different than those triggered by intracellular bacteria. Which component of the immune response is induced first by a viral infection?
So that would be correct, type 1 interferon. Remember, that's the first thing that is going to be produced, part of the innate immune response for viruses.
So is that produced by the infected cell?
So that can be produced by the infected cell depending on what type of infected cells. Remember, plasmacytoid dendritic cells also are going to be really important. They are specialized actually to produce type 1 interferon in response to viral infection. So cytotoxic T cells, obviously, that's not early. B cells, it's not going to be early. NK cells will come second.
To keep with the inflammation topic here, Dr. Fernandez will.
Right.
Yeah, sorry about the seats in this room. Oh, yeah.
No, but I didn't.
So you're just going
Okay.
Okay.
Okay, so I posted 7 questions So these were taken from the Robbins and Cotran review of pathology. So if you've done those, you've seen these questions. But the reason why I chose these is because they cover the material that they cover in the lecture or in Pathoma. I was asked to submit 3 questions from my lecture and 4 or 5 from Pathoma, but they all pretty much have it's the same material. And I like them because also this is the same type of questions you're going to be asked on the board and on the exam. So here in the first one we have it's a 70-year-old man with emphysema, but also has some heart problems. But in the last few days he has fever and difficulty breathing, and chest X-ray shows accumulation of fluid. Can also be called effusion. But they take out the fluid, has a specific gravity of 1.03, and neutrophils. So they're asking what's the likely cause for accumulation. What changes induce this accumulation of fluid? What? Yeah, here the right answer is E, vascular permeability. What gives you the clue? So the density is high. Remember, we talk about transudate and exudate. Transudate has a specific gravity less than 1.02. So this one has more proteins and has cells. So that's characteristic of inflammation and of exudates. And what causes that protein accumulation? Increased vascular permeability. So that's why that's the right answer. Any questions about any of the other ones? No? Okay. So remember differences between transudates and exudates, and what are the mechanisms that result in an exudate. This is a 35-year-old man also with increasing dyspnea. Chest radiograph shows pleural effusions. Also the fluid is taken out. It has a cloudy yellow fluid, and the cytologic examination shows also many neutrophils. No lymphocytes or red cells, and they're asking which of the following mechanisms contributes to the pleural effusion, the pleural fluid accumulation. Yeah, you said B. So in this case, the right answer is B. Remember, it has this is what? This is exudate or transudate. It's an exudate, so it has many cells there. So it's definitely an exudate due to inflammation. So what's specific about this inflammation? So again, this changes to vascular permeability caused by the contraction of endothelial cells. Yeah. Any questions about any of the other possibilities?
Why are lymphocytes and red blood cells not
Well, remember, neutrophils are the main acute inflammatory cell. So this produces acute inflammation, and the majority are going to be neutrophils. Maybe this has been going on for a while. I'm sure you'll probably start finding some monocytes and lymphocytes. Okay, so I guess you have to make the jump from this is an exudate, so that's because of inflammation, and inflammation is associated with vascular permeability, and vascular permeability results from endothelial cell contraction. So there's many jumps, but you just have to follow the trail.
Would you only see red blood over here?
Yes.
Would you only see red blood cells if there was like a vascular injury, or do they make it out?
Some of them might make it out, but usually there's some kind of damage to endothelial cells. Yeah. Yeah, they don't have an active process to get out of the tissue. Only if there's some break in the endothelial barrier. So number 3, this is a woman who is allergic to cats. And then, of course, during visit, she inhales cat dander. With immunity, develops nasal congestion and abundant nasal secretions. And they're asking which one of these substances is likely to produce these findings. Here, C?
Yeah.
Yeah. So in this case, what's happening here, we haven't talked about allergies yet. We're going to talk about those, but in this case, it is the mast cells that are being triggered by these allergens, and they're going to secrete histamine. And what will histamine cause? Yeah, vasodilation and increased vascular permeability. In this case, it's upper respiratory tract symptoms. So again, this inflammation is going to cause the nasal secretion and congestion. Okay, any questions about some of the other mediators? If you suffer from allergies, you knew this one, but you'll be taking antihistamines. Another one about mediators. This is a 35-year-old woman taking aspirin for arthritis. And of course, that reduces her joint pain, but inflammation continues. And they're asking, the aspirin therapy alleviates her pain mainly through reduction of which one of these mediators? E. Again, right answer is E, so it's prostaglandins. So what does aspirin inhibit? So the cyclooxygenase, which is responsible for prostaglandin production. Okay, any questions on some of the other ones? What about leukotrienes? Yeah, that's lipoxygenase. They're all derived from arachidonic acid, but this is the lipoxygenase pathway. So this is a 35-year-old man with mid-epigastric pain last 3 months. And endoscopy shows ulceration of the gastric antrum. Endoscopic examination from the ulcer shows angiogenesis, fibrosis, and mononuclear cell infiltrates with lymphocytes, macrophages, and plasma cells. So which of these processes best describes what's going on with this patient? So what are these, what is angiogenesis, fibrosis, and mononuclear cell infiltrates characteristics of what type of inflammation? Chronic. Yeah, exactly. So in this case, the right answer would be B. That's a chronic inflammation. Don't get, yeah. Sorry? Yeah. Yeah. Don't get thrown out. This is an ulcer. Remember, we talk about ulcers also being some of the presentations of acute inflammation, but ulcers are normally associated with chronic inflammation because they stay there a long time. Yeah.
What would fibrinous inflammation, how would that be different?
Which one?
Fibrinous?
Yeah. Remember, fibrinous inflammation is usually in a cavity, like pleural cavity, in the heart, and that's when fibrin leaks out, and you have deposition of fibrin in that cavity. So that would be the fibrinous inflammation. Of course, granulomatous inflammation is chronic inflammation, but it's usually you have some antigen that the immune system cannot get rid of. And serous inflammation, remember, born, they just get this fluid in a vesicle. Just 2 more. Another one about mediators. In this case, it's a boy with chronic cough and fever for a month. X-ray shows enlarged lymph nodes, bilateral pulmonary infiltrates, and sputum has acid-fast bacilli. That's a mycobacteria. This biopsy specimen shows granulomatous inflammation, epithelioid macrophages, and giant cells. And they're asking which of these mediators is likely contributing to the formation of these giant cells. Yeah, in this case, it's B. Right, we just talked about interferon gamma inducing Th1 and activating macrophages. So the most important cytokine in the granulomatous inflammation will be interferon gamma. And the last one, again, more mediators. But this is a 42-year-old man with some septal defects, but he develops cough and fever for the last couple of days, mild increase of temperature, but a blood culture grows Streptococcus viridans. Dr. Miller probably will talk about that. He has he has an infection, probably a heart valve, probably. And lab results show increased erythrocyte sedimentation rate, and shows also the microbial cells are also opsonized and clear. And they're asking which of these chemical mediators is most important in producing these findings: increased sedimentation rate and microbial clearing.
C-reactive protein. B.
Yeah, in that case, B is the right answer. Why? So remember, increased sedimentation rate is due to acute phase proteins, and which C-reactive protein is one of those. So that will lead to changes in the red cells, and remember the rouleau formation, so that will make the blood erythrocyte sediment faster. And C-reactive protein is also involved in complement activation and opsonization of the bacteria. Okay, any other questions about any other possible answers? No. Okay, so as you said, this is very heavy geared towards mediators, so make sure that you understand all these mechanisms. Okay, thank you.
That concludes the immunology. We're only scheduled to go to 12, but we can keep going. And so Dr. Strikes is here and I'm here. I just have one comment on my material. I gave you practice questions that are sort of representative. Just have one additional comment. I'm going to send an email because not everybody's here to hear this. But in the lecture on normal microbiota, I gave you a lot of practice questions on knowing sort of which bugs are where on the different parts of the body. So you need to kind of know that. In addition, you need to know sort of the characteristics of the environment in that area that sort of is responsible for that. So you need to know the intestinal tract is anaerobic, for example. That's the kind of thing. You need to know that most of the mucosal surfaces are wet, but the skin is dry, and dryness impacts what grows on the skin. So those kind of things. So there'll be some questions on that. The other questions I think are pretty representative of the material you need to know on my stuff. If there's any particular questions, I can answer them, but Dr. Stripes is here. I'd like to bring him up to answer any questions related to microbial genetics or any of the material that he had. He has some soft shocks too. Any other questions while he's coming up on my stuff? Oh, good.
I'm going to make a quick comment about my questions. I will post some examples, but I don't use vignettes. I'm mostly testing for your knowledge of the terminology so that you can understand the concepts and speak the language. That's my role. I've dropped into this course and then I'm gone. So I'm trying to teach you not how to synthesize stuff so much as start to speak the language. So it'll be like a lot of which of the following questions. Which of the following is the difference between a BCI and an antibody? Boom, 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 boom. Feel free to email.
Okay, you folks have been here for a long time, so I'm not going to be long either. But I suspect that many of you probably have a question about this. How this is done. Okay, well, these are all patients. These are actual patients from University Hospital. And what you do is you take the bacteria and you lyse them and you isolate the plasmids.
Hey, Aldous, can you use the microphone, maybe?
And you use a mic. Okay, so these are all patients, and you isolate the plasmids, and you cleave them with endonuclease, which cuts at specific spots on the DNA, and you run them on a gel. The heaviest ones are up on top, the lightest ones are down on the bottom. So the question was, which are identical? Because that's what the lab wanted to know. So if you look at 2, 3, well, 2 obviously is different. 3, 4, and 5 may be kind of similar, but if you look, there's some of these are a little lower than others. If you look over here at 9, 10, and 11, and you can pretty much go across, and you can say, yeah, these are all identical. That's it.
So
Yes?
was there an actual question associated with that?
I sent you out the questions.
The question was missing on
There
this
wasn't
one.
a question. I found.
No, we got it.
The question was, which lanes are identical?
Oh.
Yeah. And so, a lot of folks have probably put down 2, 3, or 4, 3, and 4 basically, but it's these guys that are identical. And so these patients had the same bacteria with the same plasmid, same infection, and that kind of thing. And you will get this on the board, and you will get this on our test. You'll get where you're going to have to identify where the plasmids are and that kind of thing, and so on and so forth. Okay. Any other questions for me that haven't been answered by email or any way, shape, or form? Okay, well, if you guys are satisfied, you can always email me. I'll have my
Or any of us.
email me over the weekend or whatever, and I'll be happy to answer any other questions that may be bothering you from any of the ones that I sent out or that were with the handouts that I had. Okay, well, listen, good luck to you guys Monday.
And by the way, we think that this has been videotaped, if that's helpful, and I'll find out where it's going to be uploaded. And Sam has exhaustively been audio recording this whole thing with her little elbows planted there. So poor girl. I don't know if anybody else has, and you're going to upload.
I'll upload this to probably
Hey,
Facebook.
Nick, one additional comment related to my microbiota because it relates to the woodcutter here, you know. And so the question is, talk about the bloodstream and the spleen and what gets into the bloodstream. Remember microbiota, the blood is considered not colonized, but you frequently find things in the blood, transient things. So we didn't go into this in great detail, but we'll go over this later. I mean, you're always constantly getting bacteria invading across epithelial surfaces, trying to get into the bloodstream, to get rid of them. Every time you brush your teeth, every time you chew, you get transient little bursts of bacteria going into your bloodstream. But we clear them, so all those are successes, and the spleen is really involved in it. You know, so remember the blood. That's why you take multiple blood cultures, because you can occasionally get a colony in a blood culture. It's not supposed to be there. But repeated blood cultures are what you're looking for infection. You know, so.
Okay, if there are no other further questions, go to lunch and do all those things.